Welcome, and thank you for joining us today for leveraging clinical narrative text at scale, applying natural language processing to understand the patient care experience. My name is Jennifer Schaefer, and I will be your WebEx host for today's webinar. A few housekeeping items to go over before we begin today's presentation. All lines have been muted upon entry and will remain muted for the duration of the webinar. You may submit your questions at any time using the chat panel and select all panelists from the dropdown. If you don't see this, you may need to select the appropriate box within the lower navigation panel and selecting chat. Closed captioning is available via the chat box. And with that, I'd also like to note that today's webinar is being recorded. And with that, I will turn it over to Roxanne Jensen.
Thank you so much, Jennifer. Here's a list of the presenters and panelists that you will be hearing from today. And here are some of our webinar goals for today. It's to highlight different natural language processing NLP approaches to electronic health record and related clinical free text data to better capture and understand the patient care experience, and to explore point-of-care application of NLP methods from the provider perspective. We're going to end after our 4 presentations with a panel discussion where we will discuss barriers and research opportunities in cancer and healthcare delivery research. And we'll also be taking your questions. Either you've submitted them ahead of time using the hashtag here, emailed, and then also you can also submit questions during the presentations in the text box. Oh. Oops. Okay. So this webinar is really aimed at people interested in natural language processing, but we're not assuming that you may have a lot of knowledge or use of it. So I'm going to lay out a very brief overview of what it is and kind of what we're talking about here. And we'll leave the more detailed discussions and some really great examples to our presenters today. Natural language processing is an automated method that combines computer science, computational linguistics, and content expertise. It extracts meaning from unstructured data, but it's more than just free text coding and identification. It can be used for a lot of different other tools. It can be used to summarize large amounts of free text information, sentiment analysis, so positive or negative feelings that are in text. It also is the basis for conversational agents that you may talk to online, chatbots when you're trying to get questions answered. So it's the backbone of a lot of what we see around us. This is what a manual chart review looks like, or abstraction, and a long-standing way of reviewing clinician notes. Notes are pulled, reviewed, and coded by a data annotator, and this is that blue line you see here. So someone with content expertise. Validation occurs on this orange line, where an example could be someone dual coding, looking at agreement between records by another person. And then the annotated data can then be used to inform clinical care and research application. This is a slow and laborious process, and a good example of this in cancer research is in how, until probably pretty recently, cancer pathology reports are manually abstracted by cancer registries to understand cancer incidence and trends. This is how workflow changes with the application of NLP methods and models. They're still using an annotated data set as the foundation, but you can see that some of the, there's more automation in the process. The machine learning or natural language processing annotated predictions are using a model, and then that's fed into the validation of the model occurs over here at the orange line. And so the human level of review or supervision happens later in the process. They are not laboriously coding a single piece of information that comes through. But the validation process is very important because these models are iterative. So matches are identified or not, and they're reported back, and there's a feedback loop, as you can see here with the gray arrow. The annotated data set that's created is then also used for researchers and clinicians. But you can see that this is something that you can go through a much larger quantity of data, and that is what's necessary when we're talking about applications in electronic health records and large-scale use. There are two basic categories that we will be highlighting today of NLP models. These are broad categories, and there is overlap. There are rule-based NLP models, and these are algorithms that are predefined vocabularies, and they can include very complex logic. They have standard terminologies, and updates that happen due to maybe a misclassification or an issue, they require manual updates to the logic. Machine learning, in contrast, also uses probabilistic statistical modeling. And this is adapted based on kind of what findings are in the training data. And it's a very iterative model as well. But the changes are automated. So while the review process is by a human, the changes in the model can be happening in real time. And so, putting this all together, you can see that the method of data abstraction and the level of automation are really important as to the scale that this can move at. Human coders and abstraction, you can see that this is all very manual and it's slow. You can see here it says about 50 patient notes a day is a reasonable goal. Rule-based NLP requires expert review, but is a bit more automated, and this jumps up. Machine learning NLP is automated, and you can see how the speed increases exponentially. And these talks coming up highlight all of these methods as well as hybrid approaches. So I think to sum up just before we get into the good stuff, what is the value of NLP here in healthcare delivery research? Structured EHR data reflecting the patient perspective, symptoms, function, quality of life, we have it, but it is limited. NLP allows researchers to identify many new types of patient-focused information in EHRs. They're not well captured in structured fields, and you're going to see examples of that today. And then also, it can be applied to content that's already captured in the workflow. So there's a lot more information that we can have, code, and use without the additional collection burden. And it's just a very compelling argument for what we're trying to do here and the type of research that can be done. Okay.
All right, so I'm taking over now. I'm just sharing my screen here. Make sure I can share this. And I'm going to go over here to presenter view. Okay, how does that work? Do you see my screen? Okay, perfect, great. So good morning and thank you for coming today. I'm really excited to share some of the work we're doing on the intersection of data and technology to advance our work in cancer research. I really want to thank NCI for organizing this webinar, and especially to Roxanne, who's just been, key to pulling this all together. And so today I'm going to share our work we do using NLP. I'm going to focus on treatment-related side effects in unstructured text in EHRs. Now, we use NLP across many different entities, but this is my focus for today. So let's start with some background on treatment-related side effects. As you likely know, cancer treatments can cause debilitating side effects. And many of these side effects are patient-reported outcomes. And a patient-reported outcome is a symptom or side effect that can only be reported by the patient. There are no laboratory tests or devices to capture this information systematically. Therefore, patient-reported outcomes are not routinely captured in a patient's health record. And when they are captured, they're stored in unstructured data, either in a clinical note or as a patient email, et cetera. And so this makes PRO, patient-reported outcomes, very difficult to evaluate at the population level. However, it's important that in a patient-centric value-based care system, the net effect of treatment must include assessment of these treatment-related side effects. So it's November, and November is Prostate Cancer Awareness Month. So I'm going to use a use case this morning on prostate cancer. So let's talk a little bit about why side effects are so important in prostate cancer. For localized disease, which is about 90% of diagnosed cases, 5-year survival rates are excellent, and patients have important treatment options. For example, they can choose surgery or radiation. And each treatment option is associated with a different treatment-related side effect, such as urinary incontinence, erectile dysfunction, or bowel dysfunction. And given the excellent survival rates, patients often live a long time with these side effects. And because PROs are so difficult to capture at the population level, there's limited evidence to guide treatment choices and shared decision making. So when you have the patient and clinician talking, how do you guide a patient with either surgery or radiation if their quality of life, urinary incontinence, or erectile dysfunction is directly related to that choice? So I set out to leverage my skills in data and technology to better understand how and where we can find these treatment-related side effects in electronic healthcare records. So to understand patient outcomes and therefore their holistic care experience, we have to first understand EHRs and that they capture just a portion of the patient's experience. And we know this. So over the past 5 years, we've developed a resource that Prostate Cancer Clinical Data House, where we take our EHR data, we link it to our Institute's cancer registry, and then we link that further to the California Cancer Registry to get a better capture of patient survival, patient outcomes, treatment outside of our institute. And in this warehouse, my team usually approaches projects in 3 components. So we first focus on capturing diverse data, as I just mentioned, linking EHRs with cancer registries, etc. We then focus on transforming that data to knowledge. And here's where the NLP comes into play. And then we take that knowledge and we move it to point of care to try and improve patient outcomes. So we're talking about NLP this morning. And so transforming data to knowledge is a key aspect of our work. And I want to talk to you today about 2 approaches that we use. So one is a rule-based approach, which Roxanne briefly mentioned in her overview. And for our rule-based approaches, we work very closely with our clinical experts and domain experts to create dictionaries that we can use to search for mentions in the text. We also use a weekly supervised pipeline using neural word embedding, where a weighted function of neural word embeddings is used to create a sentence vector representation of the words we want to extract from the text. And then these sentence vectors are then used as input for a multinomial logistic model, where the output is either the presence or absence of a symptom or side effect we're looking for. And then these classifiers are used to train a model. So today I want to show you how we've used this framework to identify, I'm going to focus on urinary incontinence here. Urinary incontinence is a common treatment-related side effect in prostate cancer patients, more commonly seen following surgery rather than radiation. And here is a graph from some work that was published in JAMA in 2017 that shows urinary incontinence following 3 common treatments, surgery, radiation, and active surveillance. And here we see that after surgery, patients generally report urinary incontinence at about 30 to 40% immediately following surgery. And then it kind of falls up to about 30% for the remainder 36 months after surgery. So this is a very common and important side effect that affects quality of life. So we first set out to identify where and how the UI information is recorded in the patient's healthcare record. This table shows that when we looked at 5,300 patients receiving prostatectomy in our healthcare system, only 4 patients had an ICD code of urinary incontinence. Now, remember, I just showed you that about 20 to 40% of patients suffer from this side effect based on survey data. So this is really underrepresentative of the extent of this side effect. So next we used a rule-based NLP approach on the same cohort looking at clinical notes, and we found 450 patients, so about 10% had documentation of urinary incontinence in the EHRs. And more importantly, we're able to find that over 1,000 patients reported that they had no urinary incontinence, so a negation of urinary incontinence. And in our rule-based approach, here are just some sample sentences that we use to identify and label our data. So the first sentence, in the note, it was written, he is dry most of the day, but uses a diaper at night. So diaper is our key word here. So we labeled that patient as incontinent. The next sentence, these include bleeding, possible blood transfusions, infection, wound dehiscence, incontinence. That was labeled as discussion of risk following surgery. And then the last sentence, patient denies incontinence. That was, of course, labeled as negated incontinence. So after we used the rule-based approach, we moved to a supervised approach, a weekly supervised NLP approach. And here, what I want to show you are just some of the key words that were coming out when we're scanning the notes for using NLP for urinary incontinence. And at Stanford, the words that were that were coming out as most frequent were diaper, incontinence, leak or leakage, risk, etc. We then took our algorithm and we applied it to Dana-Farber. And while we saw good similarities, we also saw differences. So for example, Dana-Farber was more likely to use the word bladder when talking about incontinence. And at Stanford, we were more likely to use post-void. Another important difference we found was the word of the brand name depends. So at Dana-Farber, it was often written in the notes that patient wears depends, meaning the name brand diaper. As we're at Stanford, we didn't use the name brand, and we would most likely see a sentence such as urinary incontinence depends on physical activity. So this really highlights the need for cross-validation of these algorithms and really local terminology that's not used across systems. So you might ask, how well does the clinical documentation of these patient-centered outcomes correspond with what the patient's saying? So here's some work that looks exactly at that question. In this figure, the green line represents the percent of urinary incontinence cases out of our total prostatectomy cases over time, and that had a clinical documentation of urinary incontinence. And the red line represents what the patient has reported in the validated EPIC 26 survey to assess urinary incontinence. You can see here that the documentation in clinical notes is very concordant with what the patient is reporting in the survey until about 12 months. After 12 months, they start to diverge, and I think that's another topic of study. So we're now able to use the data and technology to identify, extract, and analyze patient-reported outcomes in the health data at a population level. So what about symptom severity? In order for this work to be clinically meaningful, we have to do more than simply identify if a patient has documented incontinence or not. We actually have to know the severity of the symptoms so that we can better understand the patient care journey across a spectrum of side effect. So for example, for a patient with mild urinary incontinence, you advise them to perform a Kegel exercise, whereas somebody with severe incontinence might have surgical options. So understanding the differences in the severity of these is important from a population level to understand, how this affects the care trajectory. Different approaches, we classify patients with urinary incontinence into 3 categories based on standard definitions of mild, moderate, and severe urinary incontinence. This first table shows an example of some of these sentences that we tagged in our words and how we classified them, and also some of the key words that we used. And for the study, we found that the rule-based NLP approach outperformed the other models, which could likely be due to the class imbalance. So we had very few patients with severe urinary incontinence, but also could be due to our small sample size. So in conclusion, I think it's important that we think about a learning health system, and successful learning health systems transform data from routine care into evidence that provides optimal care to each patient. In order to learn outcomes, particularly patient-reported outcomes, robust patient phenotyping is needed to first identify PROs in the health record, and then to classify patients' disease severity. Symptom severity poses extraordinary challenges for a precision medicine approach, but its classification is essential to learning through care delivery and can ultimately improve the care provided to patients. So in conclusion, important treatment-related side effects are often documented in EHR clinical notes, and we have found that this clinical documentation is concordant with patient surveys. Rule-based approaches are often adequate and at times superior to machine or deep learning NLP approaches, but it really depends on the question you're asking and the type of data you have. We show that phenotyping patients based on severity of symptoms is feasible and essential to advance patient-centered care. We can use this data to help personalize recommendations for management approaches and also guide population-based studies to advance patient-centered care. With that, I want to thank my team. This is not a single discipline project approach, right? Our approach requires heavy investment from our clinical investigators. We have staff, we have postdoctoral fellows, we have medical students and graduate students in order to. And finally, I want to thank NCI for this funding. This is funded from an R01 under NCI. And with that, thank you, and I will stop there.
Hey, can everyone hear me? I unmuted myself. Oh, thank you. Thank you so much for the opportunity to present today. I'm Charlotta Lindvall, and I lead a research lab that focuses on building and sharing natural language processing methods that capture the experience and care quality of seriously ill patients using text and audio data. It is so extremely important that we can assess care quality for vulnerable patient populations, such as patients with life-limiting illnesses. In addition to treating their illness, we also have to make sure that their symptoms are well treated and that communication about goals and priorities take place. The challenge is that routine assessment of many established quality indicators is nearly impossible. The information is embedded as unstructured free text within clinical notes. And a key example of this is timely documentation of goals of care. So structured data, such as like lab value or blood pressure, it's very easy to access in the EHR because it's structured data. And so it's much easier to use this type of data for quality measurement. In contrast, patient experience, such as symptoms or the example I will give you today, goals of care documentation, that's in the unstructured, it's unstructured, it's text data. And so this documentation, it often gets buried within hundreds of clinical notes, and it requires manual chart review to find, and therefore it's very difficult to build quality measures using this type of data as opposed to structured data. So one solution to this that many healthcare systems use is to try and make the unstructured data structured. So in the example of goals of care documentation, Epic has built a tab to enter some domains of goals of care. So clinicians then are supposed to go into this tab and fill out whether or not what the patient's hopes and worries are and what kind of prognostic information was shared. But I see two key issues with doing this. One is that often when you try and make something that is highly complex, when you try and make it less complex, in this case, you try and make a patient's hopes and worries into checkboxes, you lose a lot of information. So in this example of the Epic tab for goals of care, hopes are basically 7 different checkboxes and similar to worries and prognostic information. And so you lose a lot of granularity in the information that was actually shared between the patient and the clinician. The second barrier is that clinicians, they don't use these tabs. So even though we can ask them to use the tab and ask them to put in their goals of care documentation in this specific structured data field, they tend to forget it, or they don't do it for various reasons. And there was a recent study published in JAMA Oncology that showed that at Penn, less than 4%, a minority of patients with advanced cancer had anything documented in their EPIC tab. So in contrast, we have this very rich documentation. We know that clinicians, everyone who interacts with a patient have to document that encounter. So I think the key message of this webinar is that natural language processing, it holds such tremendous promise in capturing this information that is truly very granular and patient-centered. So here I'm showing an example of a note from a patient who was admitted to the ICU, and the clinician has documented that his family, 2 daughters and a son, are all in agreement that they would like no heroic measures, no blood transfusions, no resuscitations, no blood pressure interventions. They would like comfort measures only. However, they would like their father to remain intubated until they arrive. This type of information would be very difficult to fit into checkboxes. And so, because I'm a palliative care physician and researcher, and this is my topic is at the intersection of serious illness and natural language processing, we have set up this infrastructure in my lab to really push validated quality measures into NLP models, so that these measures can be tested and assessed at the population level. And as Roxanne mentioned earlier, we still need that human in the loop. So it's not fully automated, but what the NLP method does is really reduce the burden of manual chart review tremendously, because manual chart review, we can't review millions of notes, but with NLP, we actually can. We can move these assessments to the population level. So in the next couple of slides, I will walk you through an example, and I'm using a measure from the National Quality Forum. They have several measures for end-of-life care and palliative care, and I will show you how we operationalized measure 1626. Measure 1626 states that it's a measure of the percentage of vulnerable adults admitted to intensive care unit who survive at least 48 hours, who have their care preferences documented within 48 hours. And so the denominator is patients who are age 75 or older at the time of ICU admission. And the numerator, again, is that documentation of care preferences that take place in the clinical notes. So in order to operationalize this, as I mentioned before, we do need that clinical expert, the human expert in the loop. And so for this project, we had 6 clinicians developing a gold standard for NQF. So all the notes that we used to train the model, they were triple coded. So we had 2 clinicians independently code clinical notes, and then a third clinician coder went in and added labels, indications that care preferences were documented that were missed by the first two human coders. And I'm happy to share we use annotation softwares for this process that makes it much, much easier than reading through clinical notes and using Excel or REDCap or anything like that. So I'm happy to share that. And then when we have the labeled data set, we use that data set, we use it to train a model, so it's our input data. We often, in these models, we use about 80% of the data to train a model, 10% for optimization, and then 10% to test and validate, to make sure that our NLP model is actually capturing what we wanted to capture. And after a model is validated, we can deploy it. We can actually apply it to the population data and see what's happening at the population level. So what we found in this project, remember that the gold standard was generated by 6 experts, 6 human experts. They went through, they had the triple coded. It took actually a couple of months to develop the gold standard. What we found in the end is that the NLP model outperformed each individual clinician coders. So the NLP compared to the gold standard, which was the data set coded by the 6 clinicians, NLP found the documentation with 93.5% sensitivity and 91% specificity. And I'm giving a range for the human coders because we compared each human coder, what they labeled, we compared to the gold standard, which was the triple coded data set. And each, even though these were experienced clinicians, their sensitivity was in a range of 77 to 92% and specificity 78 to 97%. But what is more significant here is that the speed. So the NLP method was over 18,000 times faster than the clinician coders. And here on this slide, I'm showing you examples of what the NLP model identified. The NLP model identified word-by-word documentation of patient care preferences. And in green is an example of documentation where there was perfect alignment between the human clinician coder and the NLP model. So the first example, it says, we were approached by the patient's family who wanted to speak to palliative care, hospice, and wanted her to be DNR-DNI. So that was something that both the human clinician coders and the NLP model identified. What was so interesting to us is that the NLP model found documentation that even after we had 6 clinicians go through and generate the gold standard, there was documentation that were missed by the human coders. So an example in blue that was only found by the NLP model, and that so it created a false positive, but when we went back and reviewed all the false positives, most of them were really true, were actually documentation. So the first example, it was documented, discussed with daughter and healthcare proxy, who says that patients in the hospice program were bridged to DNR-DNI CMO, but despite multiple conversations, the patient insists on being full code. So that's clearly qualifies towards the NQF 1626 measure. And then we also, because we've built this model, we were able to analyze the performance of the measure at the population level in 5 intensive care units. And this information, that we can run this type of model and identify how different ICUs perform. And even like we could, if you look on the y-axis, it's documentation probability. So we could even identify at the physician, at the clinician level, how likely they were to document care preferences within 48 hours. So this type of information is so useful to drive quality improvement, and also to be used to look at research studies that have like an intervention to perhaps try to improve this type of documentation and communication in the intensive care unit. So what I think my team, what we have learned from doing this work is that NLP can be applied to assess validated process measures. We shouldn't reinvent the wheel. We should use the measures that have already been validated and try to operationalize them using NLP. NLP is faster, more accurate than human coders, and it's scalable to the population level. And one very, very important goal for me and my team, for the lab, is really to think about how we can disseminate these NLP methods and how we can make them more accessible to clinical researchers. And I'm excited to share that we have built NLP software that's easy to use. It's called Clinical Regex. And at this point right now, it's being used in 2 large NIH-funded trials to identify the primary outcome of those 2 trials, that is documentation of advanced care planning. And we're also collaborating with the VA to operationalize quality measures for palliative care. And I would also say to this that I think working with different healthcare systems, and I know the other panelists share this goal with me, that it's so important that we build learning collaboratives and that we test our models across healthcare systems. So I just want to end with a slide. My PhD is in medical genetics, and I think the Human Genome Project that really shows how access to new data can revolutionize medicine. We now have targeted drug therapies for many types of cancer, and I think about patient-centered data the same way. Like, we need access to this data. We need to be able to study outcomes. And I strongly believe that accessing patient-centered data, symptoms, communication outcomes, could really transform patient care, and that also bring the data to the level of importance that it actually is. It's hard data, just like a DNA code is hard data. This patient experience data is equally important. So I want to thank my lab. It's wonderful to work with you. I know some of you attend today, so thank you very much. This is definitely a cross-disciplinary, this is not a project you do on your own. And you need different specialties and expertise to really push this work forward. I also want to thank my funders, and especially the Purva Jaffe Family Foundation, who provides essential support to build the research lab and to support dissemination of this work. So thank you very much, and I will hand over to Imon.
Thank you, Charlotta. It was a very nice, informative talk. So I will continue my presentation afterwards. So I'm an assistant professor in Emory with joint affiliation in biomedical informatics and in radiology. My background is computer science, but I started doing NLP during my master, then PhD, postdoc, then like long path within NLP. But as Charlotta also mentioned previously, that patient-centered outcome exploration using NLP is like so important topic. It can really change the treatment care pathways, because you are taking into account the symptoms that is coming from the patient itself into account, which is very, very important. But as also like Charlotta, Tina both highlighted, that only ICD code is not really sufficient to extract those information. So this is the study we started doing with breast cancer patient, where we are comparing our manual curation, where we ask two oncologists to look at the clinic notes and give us the outcome that we are focusing on. So our outcome for this case was recurrence of breast cancer, monthly distance recurrence. And then we are develop an NLP model, and then we are comparing that performance with ICD-9 and ICD-10. So as you can see that NLP model and manual curation was very close to each other. We missed only 3 patients. We missed 3 patients because the manual curator actually were looking at medications and other types of procedure code to fill up that gap. But those we in NLP actually we were only analyzing clinic notes, so we missed those 3 patients. Other than that, NLP performance was very close to the manual performance. But when we started analyzing only with ICD-9 and ICD-10 codes, we see that we missed a lot of patients who had recurrence. So this shows the fact that NLP can actually encounter a lot of like outcome data, which was not properly captured by structured information. So we built that NLP model, and we validated on this 180 patient, which was prospectively collected. So we didn't have those patients when we were building the NLP model. And then actually we run the NLP model on 10-year breast cancer data from one single institute, where we have more than 10,000 patients. So as you can see here that then we are comparing with California Cancer Registry and ICD-9 and ICD-10 codes. As you can see that NLP has the most coverage of the recurrence patient, where California Cancer Registry actually had 162, and ICD-9 ICD code 10 codes actually missed only like 126 patients and missed the rest. But when we started analyzing this set, which is the 90 patient where it was not covered by NLP, we saw that this patient actually left that single institution and started doing care somewhere else. So we didn't have access to those clinical notes. So that's why we missed those patients. But CCR, which is the California Cancer Registry, they covered actually all the patient who has recurrence. So it makes sense that NLP can only be applied to a single institution. When it is applied to a single institution, it can cover or extract outcome from the data when the patient still is treated on the same institution and the patient has continuous visit or encounters. This is an important thing. Then we started moving like to this fact that when we started doing like this kind of outcome analysis, we have to think carefully that this information is actually captured by the clinicians or the care team. This was not the information that is actually written by the patient himself, right? So imagine that you have two patients, patient 1 and patient 2. And so when we predict the kind of like outcome, so here actually we are looking at treatment non-adherence when the patient completed the hormone therapy treatment, and all these patients are breast cancer patients. So we see that breast cancer patients, although they have a very good survival rate, but those survival rate depends on the completion of the proper therapy, right? But we see that 1/3 of the young breast cancer patient actually discontinued their treatment early enough and didn't complete the therapy. And since they don't complete those kind of treatment, there is a chance that the patient can have recurrence. So how actually to track those patients, that understand and identify those patients early enough in their treatment so that the patient don't drop from the therapy. But when we started analyzing that why the patient is dropping from the therapy, it seems that there is a lot of side effects of this hormone therapy. For example, short-term pain, nausea, fatigue, dysfunctions, mental dysfunction like depression, anxiety, suicidal tendency, and those are actually very rarely recorded in clinic notes. So we started looking at the fact that when we started analyzing the data from one single patient, so the patient has first operative note in 2007, and the operative note says that the patient tolerated their treatment extremely well and only had the side effect of fatigue. Fine. But then the patient actually lost the follow-up. So the patient doesn't have any clinic note inside that hospital database. Then the patient come back in 2014. It says that there is a progress note which says that she is anxious to go back to the hormone therapy. That means that the patient already started the therapy and dropped from the therapy, and she is anxious even to go back to the therapy. But since the patient lost any kind of follow-up and didn't have encounter note, so we don't have any information here that we can run NLP on and extract those kind of symptoms information. So this is a kind of strange that if we don't have information, how we can complete or extract the symptoms related information from those lost follow-up time point. Then there's a consultation note, then the patient has recurrence. And then there's a discharge summary which says that post-operative nausea or vomiting. So what kind of data we can actually use to cover up for this lost follow-up data? Then we started analyzing how many encounters the patient have. We see that this patient has 45 encounters, but only there is 4 notes with symptoms. So it seems that the patient doesn't, like, care team doesn't even properly record those kind of symptoms information. Then we started creating a list of key terms for symptoms. So we were using the DSM-5, which is a very popular ontology for mental disorder symptoms. So we have a list of symptoms that we gather from there: anxiety, depression, suicidal. We take their subclass as well as the synonyms. Then we have the physical disorder symptoms: hot flash, nausea, headache, that we actually curated from NCTI, which is the National Cancer Institute terminology, Medera and SNOMED, all these ontologies. And we finally created a list of terms. So for every symptoms, actually, we have more than 10 terms, and we developed an NLP system using those terms, and we randomly selected 100, and we validated the model achieved 0.9 F1 score when validated against the manually labeled ground truth data. That means the model was very accurately identifying the symptoms from the clinic notes. But when we run it on the full data set of more than 9,000 cancer patients, we saw that there was only 8% clinic notes and 12% progress note contained any documentation of patient-centered outcome. And for as many as 30% breast cancer patients, there is no documentation of patient-centered outcomes at all. Then we started looking at different other source of information. So one source of information we found is social media posts. So as you can see here, this patient has a breast cancer self-report. So that means that this patient started talking about her own breast cancer, and they actually had all these kind of symptoms mentioned. So medications use and side effects, social engagement, mental health kind of posts. They have non-adherence kind of posts. So it seems that even if those informations are not properly captured inside the EHR, but social media posts can be used actually to extract those information. So which seems very prominent source. And this was actually not reported by the care team. This was reported by patient itself. So it is even more important that the patient is describing their symptoms on his own language. But as you know that social media has different kind of challenges from the NLP perspective, because it's not really properly formulated. There is a lot of misspelling. There is a lot of ambiguity. So we developed an NLP system which was properly identified different types of social media posts like mental health issues, side effects, and non-adherence intention. And we saw that the performance was pretty good. So we got, with BART large model, we got like 0.85 F1 score, which is like pretty good for this kind of very challenging data. And so this also shows that if we start increasing the number of training data set, our BART model performance is also improving. So that means that if we get like more and more training data, our performance can be improved. But of course, the social media, which are like open posts and which was not specific for one particular patient, we can gather as many as data as we want. So we gather 6 month data and we got like more than 3 million breast cancer patients. So which is pretty interesting. So the new information ecosystem for filling the gap in EHR, we were started analyzing the Twitter. So basically, when we started looking at this particular patient who lost the follow-up, we saw that the patient mentioned in a Twitter post, back home feeling sick, then there's a feeling nausea, then stop taking meds. So all these things were actually reported in Twitter. So it's basically, it seems that if we have proper NLP system that can use those tweets, we can actually fill the gap in the EHR for symptoms. So we developed a more complex model. So we already had that model for breast cancer diagnosis, that by looking at all the clinical encounter and the temporal timeline of the clinical encounter, this can create just a vector representation of all these temporal encounters. So basically, it's a complex pipeline. I don't want to go into detail, but I will share my pipeline happily, and it's already published. So after that, it creates this vector representation. Then we started analyzing those patients with the informed consent for accessing their particular Twitter data. So we got all the temporal tweeting posts, and we also applied our NLP pipeline as well as the vectorization and create a vector representation of these temporal tweets. So we have the vector representation of the clinical encounter, as well as we have the vector representation of their temporal tweets. So it seems that it's very nice that we have both sources of information that can fill in gap for each other. But the main problem is that for this kind of modeling, we need a huge data set. And since it involves the informed consent, it is difficult to collect those huge data set from one single institution. So that's why we have to look for multiple institutions. But as you know that this data is very sensitive, so it contains a lot of PHI. So sharing data is the biggest problem here due to the legal and ethical barrier. So we are currently exploring multiple different fusion strategies with this kind of model, where we have vector representation of both. We have vector representation of EHR, we have vector representation of the Twitter. So we are doing early fusion, where we are actually merging these two vectors together, and then we are running a predictive model on top of that. Then we are also doing the ensemble fusion, where we have two different predictive models that predict the score. Finally, we have a meta learner, which is another predictive model which finally predicts the probability of compliances. But as I mentioned before, that we don't have really enough data to train this kind of very, very complex model. So that's why we are going for multi-institutional setting, where we are applying federated learning. So federated learning actually allows us to train the NLP model without sharing the data between the institutions. So we are just sharing the model weight rather than sharing the actual data, which actually covers a lot of like a legal and privacy barrier because we are not sharing any patient data. So we are trying two different federated learning architecture. One is federated averaging, where we have a central server between Stanford and Emory, and we are doing weight transfer through the central server. But then we are also taking into account a distributed environment where we are training the NLP model in a distributed way, so in a cyclic weight transfer way, without sharing any patient data, of course. So this central server still has a single point failure, but this distributed environment actually covers that part and doesn't have a single point of failure. So we are currently doing that study and we are getting a very interesting results. So hopefully we can solve the gap in EHR. So I showed you this case study only in the respect of hormone therapy and non-adherence, but this can be actually enhanced to any other use cases and can be applied to different kinds of NLP related problem. Thank you. I will pass the slide to Julian.
All right, great. Well, thanks to my co-panelists, and thank you to the NCI and certainly Roxanne for putting this together. My name is Julian Hong. I'm a radiation oncologist at UCSF, and my research program focuses on developing and deploying computational approaches to improving clinical care. So I'll be talking a bit about how we can bring some of these great tools to the clinic, and a few applications specifically in radiation oncology as well. Just a quick disclosure, some of the work I'll be presenting is a pending patent, but all of the source code is available online. So we've heard about some really powerful computational tools. And one of the questions is, how do we take all of these great technologies and bring them to the clinical setting? And so we have all this rich data that's collected only in an unstructured format in the form of clinical notes. And then we have, but what we want to do is apply these technologies to convert them into useful information, and then bring that knowledge to improving patient care. And so there are a number of challenges that are specific to trying to translate computational tools to the clinical setting. Among these is trying to identify a clinical use case where we have a well-defined clinical problem. There's an advantage to applying computational strategies. We can translate that into an intervention, and we've seen some use cases that have been published by groups where one of the challenges is trying to figure out what we should be doing in the clinic in response to some predictive analytics. It's also very challenging to streamline these efforts into the existing clinical workflow. And as a clinician in a busy clinic, it can be really tough to add on extra pieces for the staff to try to implement to deploy these tools. There are also concerns about trust and transparency of algorithms. And then I think one of the big challenges is trying to develop high quality prospective clinical data, because we've seen that machine learning models can sometimes break down in the prospective setting, and really trying to generate high quality data where we can show that tools make a clinical impact is really fundamental to trying to translate some of these efforts into clinical care. And so the use case I'll be talking about is trying to reduce acute care during outpatient cancer therapy. This has been a point of emphasis. It's part of CMS. And so our work focused on this in the radiation space, and just kind of briefly to set the table for ways we could apply NLP to these areas. We recently published a study in JCO, which was a prospective randomized study investigating the use of machine learning to try to triage patients to more aggressive supportive care during their treatment and try to reduce the risk of acute care. So this study was run at Duke, where I was a resident, and we ran this for six months. All patients that came through the radiation oncology department there were evaluated by this machine learning algorithm. During the first week of treatment, we were able to use this to identify patients who were at high risk for acute care, which we defined as over 10%. And then those high-risk patients got randomized to either the standard of care where they were seen once weekly by their radiation oncologist, or seen twice a week with an extra visit that was carried out by typically a member of the treating team. And the primary endpoint of this study was the acute cure rate. And so we were able to show in this study that machine learning was able to accurately identify high-risk patients. So the patients that were identified as low risk had a 3% risk of acute care, which was either in a hospitalization or in an ER visit. And then in the standard of care arm of the high-risk patients, these patients had a 22% risk, and we were able to reduce that to 12% with the intervention. And so the sort of grand vision of this algorithm and approach was to combine structured data with the unstructured data that's captured in clinical notes using natural language processing. And so as you can imagine, in the clinical documentation, for instance, if a patient is undergoing radiation therapy, you have some information on their medications, their vitals, where they are in their treatment. This is structured in the electronic health record as patients progress. But there's a lot of data that we can find, especially symptomatically, that's captured only in free text. And these information that you capture, can in theory increase your ability or your confidence in a risk assessment for how well a patient is doing during their treatments. And so we asked the question of, how well can we extract or abstract radiation toxicities using natural language processing. And so we sampled 100 random free text on treatment notes. These are written by radiation oncologists during the weekly visits from the years of 2013 to 2016. And a couple of my co-residents during the time abstracted data in CTCAE version 5. And then I adjudicated any discrepancies. And the results of this abstraction have been published. And then we developed a natural language processing pipeline. And so the approach that we took was to take a publicly available option, which is Apache CTAKES. It uses a combination of rule-based and machine learning-based approaches to extracting a very broad swath of clinical data from clinical notes. So it's not use case specific. Because we were working on CTCAE, there were extra elements in our pipeline, basically to convert the output from CTAKES into CTCAE, and then consolidating across various terms which were either redundant or had sort of corresponding mapping terms in MEDRA. And extracted the CTCAE during symptoms that occurred during radiation treatment, and this study is in press. I should give a shout out to the folks in our CTSI and at the Baker Institute at UCSF, but we are working on, they are working on implementing CTAKES extractions on all clinical notes that have been written at UCSF to be made available to investigators there. And so the results of our natural language processing, I'll just kind of point out the highlights, but you can see that there is a wide, diverse set of symptoms that we were able to abstract. The positive predictive value is how likely the abstractors were to mark this if the algorithm identified it. And then the sensitivity here. The F1 is the harmonic mean between these two columns and kind of gives you a little bit of a summary. And so you can see that natural language processing using our pipeline was able to extract some of the symptoms fairly well, but a little bit more inconsistent in other contexts. And then this last column is the kappa score, which looks at inter-rater agreements between our two reviewers. And so that's on a scale of -1 to 1, where 0 is by random chance. And you can see that even across our two reviewers, there were a lot of discordance, and it can kind of give you an idea for certain use cases where our pipeline is potentially, able to offer some increased consistency in abstraction. Across negated symptoms, and this is where symptoms were explicitly stated as no pain, for instance, you can see that the pipeline that we used had a little bit more trouble detecting negated symptoms. And there are ways to make adjustments in the approaches to try to improve the detection rates of these systems. So the publicly available NLP tools such as CTAKes, there are other available tools as well. In this case, we're able to successfully extract present radiation symptoms in particular, but there are use case specific modifications that are required to sort of accurately abstract from whatever question is being asked. And then we're currently working on trying to incorporate some of this information into our clinical machine learning workflow that I presented earlier. There are a couple of extra challenges on top of the challenges for machine learning in general. Among these, the real-time data stream can be tough with clinical notes and documentation. We did do a postdoc survey to look at provider engagement, and there was a lot of interest in deploying a model now that the model was sort of proven in a randomized fashion. And then one of the things that we're hoping to work on is trying to provide better patient education to give them explanations for how computer algorithms are being implemented and sort of the decisions that are coming through from those. So a lot of people thank the collaborators and members of my lab that are working on natural language processing. And with that, I'll wrap it up, and I think we'll go to Q&A.
All right. Well, thank you so much, Julian and everyone. What an amazing set of projects, different approaches, and enthusiasm for NLP. We've gotten a lot of questions coming in already, and let's kick it off. This is a question for the group. What are some of the unique challenges you've encountered applying these NLP methods to electronic health records and other healthcare data kind of in your work?
I would say generating a high quality data set to train the model on, that's a big challenge. We initially paid research assistants to do to make the label data for us, but we now we have residents and nurse practitioners who we pay per hour to help us generate the labels, because that is so important to have a good training data set to build the model.
I would just add to Roxanne that this is a very important point. The training data set is very important, but even it is more important from the computer science perspective to gather a multi-institutional data, because even if you generate an NLP algorithm, especially rule-based, that are developed on one single institution, there is no guarantee that would be generalizable to a completely defined institution, given that the doctor's language, the template, they differ so much. But the problem, as I also described in my talk, that the problem is the data sharing because of the legal and ethical barrier. So I think that is the biggest challenge. It is even bigger than any other clinical data, because image and all the other things can be still de-identified, but in clinical text, there is no very easy way to de-identify the clinical data.
Yeah, and I'll add to that. There's been a lot of talk about available so that we can validate and test sort of a standard system. Now, there's the mimic data that's available for ICU patients, and I believe up in Boston. But, that's only applicable if your algorithm is looking in ICU patients. And it's also known that this data set is not really representative of the entire US population. It's Boston. And so really identifying federal initiatives that can help build sort of the sandbox of testing data would really help overcome a lot of these challenges.
And yeah, these are great points. I mean, I think taking this a bit further, one aspect about training data sets that we hear a lot about in the news and in research is the idea of the diversity of training sets and the implications for bias, so that they tend to be trained on specific types of people or don't have representation across minorities and other populations, and the findings can be a bit skewed and a bit hidden. What are you guys' take on this, and how are you trying to identify and address these issues in your models and applications?
So I'd love to give a response to that. So we've been looking at that very closely in our lab, and the problem is just the historical bias that's in our clinical data. So if you think about just a heart attack is a good example, where all the past clinical trials, from decades previous, have been inclusive of white males. And so the symptoms that have been recorded in our healthcare data for heart attack are really the male symptoms. So when you develop a model based on this historical data, which is what we find in claims data in EHRs, it's biased, right? It is biased, and it is not very accurate when it's applied to the broader population in, for example, identifying symptoms in women with heart attack. And so there's a lot of approaches you can take to kind of, we're never going to get rid of this historical data, but you can be transparent in the way you use it. And there's, several different algorithmic fairness models you can use to identify how biased your data is. So parity, anti-classification, calibration, which are three measures of algorithmic fairness that really take into account the bias of the data. And I think it's important that if we're transparent in, what our training data set is and how our algorithms fare in this fairness metrics, I think it is a step forward in addressing the bias.
Yeah, thank you, Tina. Any other comments from the panel on this topic?
Yeah, I actually in chat also somebody posted that comment that nicotine addiction and tobacco control. So I would just to add to Tina's point, actually. So we developed a model for understanding the nicotine use, tobacco use, and smoking cessation for MRE. And we were so excited that the model is performing so well for understanding what patient has. I don't know if you guys know that smoking status is also be recorded as a structured data, but very few time it has been filled. But then most of the time, if the patient has this kind of cardiovascular problem, the doctor also reports their current smoking status inside clinical notes. So we were extracting that, but then we were so excited that the model is performing so well. So we tested that model in Stanford, and we saw that the problem is that Stanford is like so healthy population, and very, very few people actually smoke. And so the doctor has a tendency to ask even less time that if the patient is smoking or habit or not, and it's perfectly recorded inside structured data. So there are so few patients actually that has the smoking addiction. So that is a kind of interesting that even if we try to encounter all different problems from the computational perspective, but still always the data has their own surprises, yes.
Oh. Yeah, great. Thank you, Imon. We saw a lot of different applications of NLP in your talks, but most were on clinician notes and in view a bit of the clinician kind of framework and viewpoint, with the exception of Imon's incorporation of tweets and other of media. I guess, you guys are really in the thick of this in terms of NLP methods and application, and where this is such a rapidly evolving area of research. Where do you see this going? Like, where in 5 years are we going to be, even moving beyond free text? Like, how do you see this area developing?
So I can go ahead and give a little feedback on that. So we just had a paper coming out where we're looking at patient-doctor communication. So, a lot of the clinical notes are actually not patient-reported outcomes. It's the clinician's interpretation of the patient's voice. And so we've moved a little further, and we said, well, what is the patient saying in their emails? What are they saying in phone calls? We get phone calls transcribed. And so I think that's a new way to think about how we incorporate the patient's voice in the healthcare system. But again, it's going to need the same types of methods and to extract this information. And it's a different vocabulary. So the way, a patient describes diarrhea is very different from the way the clinician is going to document that in its note in clinical notes. So there's new challenges that come when you start taking into account the patient's voice and how to apply our methods and our models to the different types of data.
Mm-hmm.
Yeah, I would like to add to Tina's point that NLP really allows us to analyze all text data. So we're not limited only to the oncologists, or we can also include data from the entire care team and also communication directly from patients. And I do think that's a strength of NLP. And I predict that we will move more and more to analyzing audio recordings too, because the audio recordings, that technology is improving. And my team, we have started looking at conversations about symptoms in audio recordings. And so I think that's kind of where we're heading in the future.
That's a great point.
I think I will just reply to one single thing. So because the method wise, the source wise, I think there is a lot of option. But another problem that we are facing currently for the deployment of such algorithm is actually having enough computational resource at the clinician front end side, because most of this model that also Tina described, Charlotta described, Julian described, that those models, especially Julian's still like the rule-based kind of, but all the other models, they are like heavily deploying machine learning, which needs a GPU and heavy memory support, even for like forward pass, even for the running and testing. But most of the time when we start deploying that model on the clinician front end, and we see that we don't have that kind of computational support, because those models cannot be deployed in the clinician front end. Of course, we can use those models for finding cohort for clinical trial, but not for supporting the clinician. So that thing, I think, to make forward with this NLP model and to really use those NLP model in the clinical application, we need to change that paradigm.
I'll add, I think there's a lot of interest in patient-reported outcomes, and with regards to PR, I think Tina kind of alluded to it, but with communications between physicians and patients, and trying to do a better job of capturing structured PROs, I think there's some good data on patients still preferring to use free text to report some of their symptoms, even though we have these tools. And I think that's a potential really good use case for using NLP.
Yeah, that's a great point. And that actually dovetails with a question that came in while you guys were talking, is that, are you thinking about ways that NLP and more structured assessment of patient-reported outcomes can be used together or harmonized in some way to help us capture more information that we might miss when we unfortunately rely on surveys and response rates?
Yeah. So that's one thing that we look at specifically in our lab. We have about, I believe we have over 100,000 PROMIS surveys, which capture patient well-being and physical well-being. And so what we've been able to do is we've been able to link patients who filled out the survey with their clinical notes and look at the comparison of that. And so that's been very enlightening, because one, we can see and I showed a graph of this quickly in my talk, but we can see how well, if the patient is complaining about a symptom, how well is that documented in the clinical notes? So are they actually saying, and there's different ways, like a patient might say something differently in the survey than they would in an email than they would to their practitioner. And so having all of those data modalities is really important when you think about the holistic picture. And that's something we do, is we link all these data sources together to get a better view of what is the holistic view of the patient journey.
Yeah. I would also like to add that for PRO, that's considered the gold standard in terms of reporting symptoms. But there are some challenges with PROs, because in serious illness, patients may not be able to fill out their symptoms on, an iPad or by phone, or there may be other barriers such as language barriers or age or access to internet. And so I think there is some concern that if we only rely on patient-reported outcomes, that may actually create some disparities in that not all patients will be able to engage in that technology. So I see using this technology to augment PRO, and like Tina said, to use all the data, different types of data, is the way forward.
Yeah, that's a great point. And so I'm gonna shift a little bit to take another question from the audience. can each panelist speak to how they address redundancy in provider shorthand and copy and pasting to avoid overrepresentation of terms? This is something we hear a lot. People say, oh, it's just cut and paste in notes, or people are now using dot phrases in like Epic where they can just expand stuff really quickly. How do you address that? And, what are you thinking about how things are moving and how free text is being utilized in the EHR records?
So I think I can answer that because we do a lot of data cleaning always. Because the first thing when we start developing an algorithm that you need, especially for the free text, we need to do a lot of data cleaning. That is for sure. And for data cleaning, one of the most important component is actually temporal analysis. So we always compare the patient current note with the previous note and see what is the new information, what information actually changed from their previous note. And we do not do that like pair to pair between one or two notes. We do it for all the previous note versus the current history note. So as you know, most of the history and physical section is always repeated. Most of the other like treatment continuation section is most of the time repeated. So we need to capture the new information. And as you know that for machine learning model, if you put more and more redundant information, you just introduce more noise to the model. So it's always better to clean the data before even like train or test your model.
Yeah, good point.
And I can add to that, and I think all of us can speak to this. People always want to come to our lab and just want to apply the most latest and greatest AI models. It's never that. The majority of our time is spent exactly on what Imon just described. It's the cleaning the data, the processing of the data, annotating the data. Rarely do you ever just come in and throw the NLP algorithm to your data set. The majority of the time is spent exactly on those processes.
Yeah, that's a good point. All right, let's see what else we have here. I think one question is that, we've talked a lot about NLP in healthcare delivery, and I'm curious in what areas in cancer care delivery research in particular you see unique potential or tailoring. What's unique about cancer research and healthcare delivery, and where do you see the real kind of interesting challenge areas for this type of use?
So I'm specifically interested in the cancer clinical notes because, as you know, that cancer is a very, very unique field. And if you look at any other field, for example, like diabetic or cardiovascular outcomes, those has like very typical types of notes, but cancer, all the information is coming from different sources. So you have to integrate radiology, you have to integrate pathology, you have to integrate genomics, you have to integrate like progression note, radiation treatment. So they have different language, they have different template, they have different style of recording information. So from the computer science perspective, it is very, very interesting when you move to any other domain than cancer, because cancer is a very typical in that scenario. So even if you're analyzing clinic note, you cannot just say like I'm analyzing clinic note. Even the clinic notes are multimodality. So that makes the problem challenging itself. Yes.
Yeah, that's a great point. Any other thoughts from the panelists? Okay. So shifting gears a little bit. I think a common goal with NLP applications like this, as we heard from Julian's presentation, are in care delivery and specifically clinical decision support, augmenting that. Julian, do you want to kick us off? Do you have any thoughts on the potential strengths of NLP-derived clinical support tools, and even some issues that may kind of come up as they're kind of more out there in the world?
Yeah, I mean, I think we took the approach of pulling toxicity data, and Tina probably has thoughts on this as well. But like, I think that we took that approach because, at the very least, that seemed like the clearest element of unstructured data that we could pull out of notes. There are a lot of efforts to address, I think. As Charlotta mentioned, our clinical shortcomings in collecting structured cancer-related data. So there's some good efforts out there as well. If you think about things like stage, study, what kinds of treatments patients have had, those things don't always exist in a structured form and are really important for cancer research. As far as clinical decision support goes, I think that sort of all of those elements can play a role, right? I think if we do a better job, if we have mechanisms to ease the capture of semi-structured data, I guess I would call it, with cancer information, it can help you sort of make sure that you're, either following evidence-based guidelines or sort of the standard of practices that you have within your clinical setting. And then, I personally just find the toxicity data just interesting, just because I think that there are, and I don't know, maybe I'm a little bit biased because that's what I work on, but I think that it can give you some really interesting predictive information that's just not captured anywhere else, and really complements other data. And I think that the most challenging thing to me about clinical decision support, as far as trying to improve, like one piece of it, I think, is the clinical decision support to make sure that we're delivering our best care now that we already know of. But the other piece of it is, how do we move the needle on how we're delivering care? And that's sort of what we tried to do with the SHIELD study. And I think it's hard because, I sort of alluded to this, but clinical support, if you present data to a physician, there's a whole heterogeneous set of possibilities and ways they can act on it. And so we took the approach in our study to actually standardize what the intervention will be. But I think, there are a number of studies that sort of present the data to clinicians, and depending on your practice, even that can be pretty diverse, and makes it harder to sort of pin down what's going on.
I would also add to that in my clinical practice, I often see patients who can't be discharged from the hospital because their blood pressure, their blood glucose is high. And it's easy to measure blood glucose and blood pressure because it's structured data. But there's so much information in the text data that probably we should be equally important. For example, a patient with very advanced cancer, and no one has discussed goals of care, or the patient's preferences for and priorities. So I think there's an opportunity to really use the unstructured text data to in the clinical care.
Yeah, and I'll just identify these, whether it's care goals, whether it's symptoms, whether it's toxicity. But I think the ultimate goal is we want to pull this information together so we can create support at point of care and bring evidence to point of care, so that the clinician and patient can discuss, okay, 50% of my patients who have criteria respond this way or respond that way to another treatment. And so it's really bringing this evidence on patient reported outcomes to point of care to better guide treatment decisions and better discuss and just augment that patient clinician relationship, because there's no way that we can expect the clinician to go through all the notes and understand at a population level all of this information. It's just too much information to synthesize. So these approaches synthesize that information and can bring it to point of care.
Yeah, that's a good point. Okay, so lots of questions. I don't think we can get to them all, but let's dive into some more technical questions. I have a question here that asks, is there any good use case for unsupervised learning, like topic modeling, to analyze patient notes? Have used this or any other unsupervised learning with good results? Interesting question.
Yeah, it's a very interesting question, Roxanne. So not only topic modeling, because topic modeling is a little bit difficult, especially when you're looking at all these types of clinic notes, but we do a lot of unsupervised learning with clustering kind of thing, because we need to identify, as Tina also mentioned, that we need to identify the phenotypes, digital phenotypes of the patient. For that, actually, we applied a lot of clustering algorithm, which runs on the vector representation of the clinic notes. So we apply like BART, like contextual language model and non-contextual language model, and then apply clustering to identify like unique phenotype of the patient. Also, we want to identify a similar patient. And similarity is judged. There is like no one single criteria actually to judge similarity. So also the similarity has been judged on multiple different dimensions. So this kind of aspect, actually, we use a lot of clustering algorithm.
Okay.
And there is some
Anyone else
published.
dabble?
Oh, sorry.
Okay.
There is some published work too on symptom clusters in cancer patients.
Using unsupervised models, or
Yeah.
Oh, okay. Oh, great. Some other questions. There are a couple of questions in here about how much data do you need to develop NLP models. As you mentioned, the data sets that you need, annotated and ready to go. You do need to put in the work to have well-labeled, identified data sets to run the models. I think how much data do you need? What additional information might be beneficial in these annotated data sets that you're working on?
The answer is more. You always need more data, right? It's always more, as much data as you can get. The more data you have,
all the data,
your models are, the diverse your training data set is, the apply it to different population. It's always more. And there's no set standard, right?
It depends too on the complexity of the data. So if the data is very complex, like goals of care documentation is quite complex, you need more data. If it's something that can't be documented in many different ways, like, a mutation or like a pathology finding, you need less data.
I'll add to that. I think kind of building off our discussion of bias and generalizability, and I think we've seen some data today about variability between different institutions. But I think with regards to how much data or where the data comes from or how diverse the data are, I think that one of the big keys is just knowing when models break down and what context they apply best in. And I think that applies to machine learning and NLP. And so if you have a very narrow use case, then maybe you're looking at a very specific data set. If you want it to be something that can be used in multiple use cases or in multiple institutions, then you need data that represents all of those different use cases where you're going to try to apply it.
Yeah. Go ahead.
Sorry, just to add to Julian's point. So as Julian mentioned, that it is very important actually to understand that how much data you need by slowly increasing. So I just wanted to mention in a computational way, it's better actually to compute that kind of convergence point. So you add more and more data slowly and understand that convergence point, that after increasing that point, even adding more data will not help your performance of your model. So understanding that convergence point of a machine learning model through a iterative process is very important when you develop any NLP tool.
And I'll just add to Julie. Okay, go ahead. I was going to say, I'll add to Julie's point. What you're asking and how subjective the concept is you're trying to extract. So if it's something very clear, like maybe recurrence or metastatic disease, that's much easier to extract than something like erectile dysfunction, where it's very subjective and it's not very, it can be recorded in many different ways. So that also takes you need to take that into consideration when thinking about how much data you need.
Okay, great. Okay, so we have 2 more minutes. I'll ask one more question, but I just want to let everyone know that this is being recorded and it will be up on the website. And we may look through, you guys have so many questions, if they're easily answerable questions about public data models and the like, we'll see if we can include some of those in a Q&A document with it, just because they seem to be very helpful for people that are looking for more information about the field. So I think just to wrap up, I think one of the things, the takeaways I really took from was the different ways you guys are kind of thinking about these models and adapting. And I'm curious how we test them. We had an example of an RCT, we have quality measurement and quality improvement. How do we stress test and validate these models for use in healthcare delivery and in healthcare delivery research? How do we actually test them out at scales that we need to know that they work well and still be safe relative to the healthcare systems you're working in? 1 minute.
So I can quickly say something. So there's been how to implement sort of these models in where you actually deploy the model at point of care and you gather information and you test it prospectively. So clinicians don't act on it while you're testing this, and then you gather information, which can capture information on the human computer interface, how it's adapted into the clinical workflow, how feasible clinicians think it is, and you got prospective validation before I think it's deployed and acted on. And so there's emerging papers coming on that. I think it's really interesting to consider that.
All right. Well, it's 2:30. Thank you guys so much. This was such an engaging conversation on this emerging topic. I had a great time. I hope you did, and I really appreciate all of the engagement by our participants. Thanks so much.
Thank you so much.
Thank you so much.
Okay.